This is a continuation of chapter 45, so this will still be the same concept, that of ineffective tissue perfusion, specifically cerebral. Now, this time the cause is not traumatic, but one of two things. So, there are two types of stroke, that is ischemic and hemorrhagic stroke. In both instances, there will be decreased blood flow to the brain. One is caused by obstruction, the other is caused by bleeding. Both will lead to increased intracranial pressure. In the case of hemorrhagic stroke, well, of course, the presence of blood, not in the vessel but in the bleeding into the brain, intracranial bleeding, will of course increase the volume of blood in the head. And as you learned in the Monroe-Kelly doctrine last week, that will lead to a displacement of the volume of another component. So as we learned last week, there are only three things inside the cranium. That is, they are mainly the brain tissue, blood volume, and the CSF. So naturally, if there is intracranial bleeding, then of course that will lead to increase in ICP. In the case of ischemic stroke, because there is a deprivation of blood flow to one or more areas of the brain, then that will lead to tissue ischemia, and eventually that will lead to necrosis, and then death will of course cause more edema to form around the dead tissue, which will cause increased ICP and will lead to more ischemia, and then we have the vicious cycle of compartment syndrome caused by increased ICP. First of all, let's look at a TIA. Now, a TIA is not a stroke. As stated here, this is a temporary neurologic dysfunction, meaning if the blood clot was big enough, or the thrombosis or the atherosclerosis was serious enough, then this will lead to not a brief interruption, but rather a permanent interruption in cerebral blood flow. Therefore, you can say that these signs and symptoms are temporary. They resolve typically within 24 hours. When they do, then this is called a transient ischemic attack, or a TIA. Lay persons would call this a mini stroke, but technically it's not a stroke, because this is only temporary. So the temporary loss of blood flow to the brain will of course lead to these signs and symptoms here. However, when this becomes a stroke, these will no longer resolve. Okay, so the signs and symptoms, the key features you see in chart 45-1, will be temporary and will resolve in a TIA. But in a stroke, then these deficits, ranging from visual to sensory, motor, and speech deficits, will become more or less permanent. So as I mentioned, there are two types of stroke. We have the ischemic and hemorrhagic. Now this will be the same concept when we go to myocardial perfusion later. And as you have learned in your third semester under peripheral artery disease, wherein you saw or rather you learned intermittent claudication in PAD. So that reduced blood flow in PAD occurred in a lower, or rather in a peripheral artery. This one occurs in a cerebral artery, and in acute coronary syndrome, that occurs in a coronary artery. But the same principles apply, meaning there is an obstruction. I'm talking specifically to the ischemic type of stroke. When there is an obstruction, whether partial or complete. Let's say, for example, in a partial occlusion, when you move, let's say when we walk in a patient with PAD, they experience the intermittent claudication, which is defined as pain the longer the patient walks, which is relieved by rest. So same thing here in in ischemic stroke. There's two types, subtypes rather. There's a thrombotic and an embolic type. Thrombotic, as you can see in table 45-1, the evolution of a thrombus, the thrombus of course thrombotic, is a blood clot. Number one risk factor for this, or predisposing factor, is atherosclerosis, this time in either the carotid arteries or the one or more cerebral arteries. Now, when there is increased oxygen demand, so let's say in PAD, it was the act of walking. Okay, so as the muscles worked harder, that increased oxygen consumption and demand, but because of the narrowed artery, lumen of the artery brought about by atherosclerosis, then there will be pain because the narrowed vessel cannot meet the increased oxygen demand. So as you can see here in thrombotic stroke, the evolution is intermittent, meaning if you go down here under the TIA, prodromal symptoms, these patients will have like an advanced warning, so they'll have one or more TIAs. So this will serve as their warning sign that there's something wrong, that unless they change the risk factors, get rid of the modifiable risk factors, which we'll discuss in a few minutes, then it can lead to a full-blown stroke one day. In embolic, there is still an TIA, in which case this is an embolus, meaning unlike the thrombotic stroke wherein the vessels involved are like I mentioned, either the carotid or the cerebral arteries themselves. In the embolic, the contributing factor here is really cardiac disease, meaning this blood clot that ended up in the brain, which of course it's a traveling clot, did not originate in the carotids or the cerebral arteries. This one, number one cause here is a atrial fibrillation, or it could also be heart failure, or it could be a valvular disorder. So any condition that would lead to blood pooling in the one or more heart chambers, wherein there's decreased cardiac output and there is blood congestion in the inside the heart, which will promote, of course, clot formation, and then that blood clot will eventually, if it misses the pulmonary arteries, meaning the patient doesn't develop a PE, they may develop a stroke. In both instances, unlike the hemorrhagic stroke, wherein this look at the onset, it is abrupt because this is the rupture of a vessel, one or more vessels in the brain. We will discuss the risk factors. Actually, it's written here. Okay, so here in figure 45-1, your risk factors for hemorrhagic stroke are an aneurysm, which is we will discuss this later in detail under chapter 38. Actually, this is in chapter 36, since this is a vascular disorder. You know about hypertension, and AVM is a as the name itself, it's describes its arteriovenous malformation, meaning this is a abnormal network of vessels wherein let me illustrate it, wherein you have, so let's say this is an artery and this is the vein. They do not normally have a connection, correct? Unless it's a fistula that was surgically created for dialysis purposes. So normally the artery and vein connection is buffered by a capillary network. So of course an artery gets smaller and smaller, becomes an arteriole, and then ends up in the capillary, and then as the way it joins the venous circulation is through venules, and then they become veins. So an AVM is an abnormal formation. This is usually forming in the brain or in the mesentery. This is the in the GI tract. Yeah, GI vessels. You can also have AVM formations there. So these are the two most common places where you can have AVM formation. But either way, these will become malformed because, of course, the absence of the capillary network will mean that the artery directly connects to a vein. Since the artery has a higher pressure, but no problem there because the arteries are made to withstand higher pressures. They have thicker walls. The veins don't. Veins, therefore, if you expose the veins to a high pressure, this will enlarge the vein. Now make it look distorted, enlarged, and weak. So the walls will be weakened, and then, of course, once you develop hypertension, so you have an AVM plus the patient develops hypertension, then that is an accident waiting to happen. So eventually the AVM will rupture and bleed. An aneurysm, on the other hand, is a so in an aneurysm, there are two types. We have a fusiform aneurysm, wherein there is a circumferential weakening of an artery. So this is an artery, and excuse me, and the walls of the artery weakens. Number one risk factor is of course hypertension. So if you expose an artery or more arteries to high blood pressure constantly over time, that will weaken the wall, causing it to dilate. Other risk factors, of course, are atherosclerosis, plaque deposits in the arterial wall that will also weaken it. Smoking, long-standing smoking can also lead to this. So this is the fusiform type. And we can also have a saccular, wherein only one side is enlarged. And we'll discuss the third type, which is false aneurysm, later when we get to chapter 38. So those are your risk factors for hemorrhagic stroke. So any of those vessel disorders, the aneurysm and the AVM, or just mainly severe hypertension, can potentially lead to rupture of the vessel, leading to that's why you have an abrupt onset here. And of course, these are your risk factors, which are hypertension, and then the two vessel disorders up here, the AVM and the aneurysm. So the prodromal symptom, there is no TIA here because it is not caused by a thrombus, neither is it caused by an embolus. So the stroke, it was caused by a rupture of a vessel inside the brain itself. So the only symptom here would be increased intracranial pressure manifested by a severe headache. Now, as stated here in table 45-1, in the CSF examination, they will be more or less normal in ischemic stroke, whereas it will become bloody in hemorrhagic stroke. And because there is increased ICP in hemorrhagic stroke and then the onset is faster, then you'll have seizures as well. And we just discussed these. Please read these next paragraphs on your own, both for ischemic and the hemorrhagic strokes. Here are our modifiable risk factors for stroke. Number one is smoking, and if you mix that with oral contraceptive use, then that's a double whammy. Substance abuse, cocaine particularly, or any other stimulants, that will lead to increased pressure. Obesity, of course, that will lead to plaque deposits. So there's sedentary lifestyle, then heavy alcohol use, and of course other stimulants that will lead to hypertension, sympathomimetics like phenylpropanolamine. No, these are the contents in your over-the-counter decongestant drugs that cause hypertension. Please read the patient-centered care here. We have this might come out as a question on which ethnic groups will be the target of your teaching to prevent stroke, as well as socioeconomic factors. They're all listed here. Now, since stroke is a commonly occurring problem, this has its own core measures. Joint Commission, the core measures will be listed at toward the end of the section on stroke. Well, I'll point those out later. That will be a test question, definitely. As I mentioned last week, I am not testing the NIH stroke scale. I believe this is a specialty area, so it will not be required of a entry-level nurse like yourself. So NCLEX will not, I doubt if they'll ask you this. I've never taught it, and nobody's come back and said, oh, we got an NIH question on the exam. So we will stick with the Glasgow Coma scale, which we learned and practiced last week. You can see there are 11 points here for the NIH stroke scale. There are 11 numbers, but C number 1 has 1A, B, and C, so that's a total of 13 points, 13 assessments. I'm not testing the chart 45-3, which are stroke syndromes. We will skip that. These are testable. Okay, so let's begin here. These are the five most common symptoms of stroke. As you can see, doesn't have to be what we commonly know as the slurring of the speech, facial droop. Of course, they are also present. They are also common, but take note that those are not the only signs of stroke. we already have chart 45-1 as listed under TIA earlier, so those are also signs, and here are also common symptoms. Now take note that the difference here is sudden. These are all sudden onset. Okay, so these are the that's the difference, because anyone can have these symptoms, right? But the keyword here is the sudden onset of these symptoms that defines them for a stroke. And I believe I mentioned these signs and symptoms also under your blueprint, which is here, right here, line 26, cognitive, motor, and sensory changes after a stroke. So that is what I'm referring to here. These are your cognitive changes right here. All right. I'm not testing chart 45-4 either. Let's go straight down here. So in this section here, this is under cognitive. Please prepare to be tested on these medical terms. Now, of course, on the exam, it will I will define or describe the patient's symptoms. Let's say I will give an example, and then you'll simply be asked to identify what that is, what that sign or symptom is. Okay, so let's say a patient after a stroke has either difficulty reading or writing, so that is dyslexia or agraphia, and then so on. Same thing here under motor changes. So please prepare to understand all these medical terms here. So we have plenty of medical terminology. For sensory, unilateral inattention or body neglect syndrome. This is very common in stroke. This is what you see in most people who have focal deficits after stroke, where they have left or right hemiplegia, for instance, or paresis. That will result in unilateral inattention, wherein they cannot feel the entire left side. So it's as if when you ask a stroke patient, it's as if the entire left side, beginning from their head, their face, their arms, and all the way to their leg, is like a foreign object, meaning it's like wearing a bag. You know, when somebody touches the bag, you can't feel it, right? Unless it's really, you know, it knocks the rest of your body. But pretty much that body part has no feeling, so therefore it's very prone to injury and inattention, meaning that the patient, let's say during ADL, so they're most likely just going to be concerned about the remaining functional body part, rather than the side that has no feeling. We will address the interventions on that under the intervention section. Please read on the assessment of the cranial nerve function. Of course, that is part of your neurologic assessment. I'll discuss your simulation before the end of today. I will describe what's expected of you, including the administration of the alteplase as well as the neurologic assessments. Okay. Cardiovascular assessment. As stated here, the part of the autoregulation in response to decreased cerebral perfusion is as you learned in traumatic brain injury, is that the body raises the blood pressure. So as you can see here, it's not unusual for a patient after a stroke that their blood pressure will increase. Okay, and we already learned last week that are we supposed to drop that blood pressure? No, we want it to be high, but not too high though. Okay, I'll show you the limits later. So this is our goal. So after a stroke, we want our blood pressure to be right around 150, 140 systolic. Okay, I'll show you the reference later. As far as lab assessments, there's really no blood test that will determine or help you diagnose that the patient is having a stroke, although there is an elevation of the WBC in response, but it's not specific to stroke. Now, what they mentioned here about bleeding times, like a PT, INR, PTT, is necessary um, for stroke, both ischemic and hemorrhagic, of course, to determine the patient's risk for bleeding. In the case of ischemic stroke, since we're treating it using with the administration of a thrombolytic, then we need to know our baseline PT-INR to determine whether or not it's safe to administer the alteplase. Yeah. So how we diagnose a stroke is the gold standard is a CAT scan, specifically CT angiography, or MRI or MRA. Either way, we need a scan. We need a visual of the vessels of the brain, which will show us whether or not it's ischemic or hemorrhagic in nature. Now would be a good time to take a break. If you'd like to pause the video, you can do so now. But oh, okay. I'll interrupt the video now.